Hello again, surgery enthusiast. Welcome back to the second part of our series on mastering thick-walled gallbladder, diagnosis and surgical approach. If you missed part 1, be sure to check it out for a comprehensive foundation. Today, we'll delve even deeper into the intricacies, so let's get started. For a better learning experience, it is recommended that you download our app available for Android and iOS for exclusive extra the premium SD content or join the channel membership. The link for everything is given in description and pinned comment section of this video. So I have no disclosure. So friends, in the first part, we have already covered the clinical case scenarios, challenges, definition and types of thick-walled gallbladder, etiology. So in this part, we will delve mainly on the diagnostic evaluation, how to reach the diagnosis, and we will also talk about GB RADS. If time permits, then we'll cover about xanthogallbladder cholecystitis. Otherwise, rest of the parts we will cover in the third edition of this series. So we left our discussion at this point that what is the dilemma. So friends, as I said, less than 3 mm gallbladder thickness is clearly benign, and if it is more than 20 mm, then we are dealing with malignancy unless proved otherwise, because chances of malignancy are more than 50%. But for a gallbladder thickness which is 4 to 20 mm is the dilemma, and it is mainly the focus of this evaluation. And again, it depends on the focal and diffuse that we will discuss as the video will progress. So these are the diagnostic basically tools available, and as we discussed in the clinical real-time clinical case scenarios, that clinical evaluation was not much of help if you remember the first two cases that we discussed in the part 1. So what are the things available? We have a USG, contrast CCT, contrast enhanced ultrasound, MRI and metabolic imaging. Sometimes you need combination and sometimes all to reach a conclusive diagnosis. And at the outset only, I want to clarify that you should not order for a FNAC if you're suspecting a malignancy in case of gallbladder. It is not recommended, or I will say it is contraindicated. So don't subject these patients to FNAC of the gallbladder to prove your diagnosis of CA gallbladder. So whenever as a resident, you are looking at the ultrasound report of a gallbladder patient, what are the things you should look for? So first thing is whether gallbladder was distended adequately or contracted at the time of examination, as the thickness of GB cannot be commented in a contracted gallbladder. So in that scenario, either you should ask for a review ultrasound, or if there is any suspicion, then you can ask for the CT scan. The thickness of the GB has to be reported in mm. Simply writing that the gallbladder wall is thickened, it is not adequate, you have to insist and request your radiologist. Again, if there is thickness, whether it is symmetrical or asymmetrical, and what are the intramural changes, that is, what are the changes in the wall of the gallbladder, whether they are focal or diffuse. We will discuss more about these changes further in this video. Again, if there is a thickening, what is the site of thickening, whether it is towards the liver or toward the peritoneal surface. As you will remember from our discussion in the gallbladder cancer management series, that the management or the staging will change. That is, if it is towards the gallbladder, toward the peritoneal surface, then it is T2A, or if it is toward the liver, then it is T2B. So just remember, B is bad, so toward the liver it is bad. So you have to ask or insist for the site. If it is toward the neck, then it has again important bearing, because otherwise the cystic duct margin may become positive if you are dealing with the growth or a thickening near the neck of the gallbladder, and that may require a CVD excision. So what are the associated intramural changes like echogenic foci cyst, which I have already said. Then again, important aspect which we will discuss again in further part of this video is mural layering. The layering pattern of the internal and external layer of the gallbladder is maintained or not. How is the interface with the liver, whether it is distinct or indistinct, whether there is a gross invasion or there are any presence of definitive extramural invasion in the form of like maybe colon or the duodenum or the porta. So all these things are required, and we have to look for these things whenever we are dealing with a suspicious case of a GB thickening. So just focus in the figures given in this red rectangle. So if what is the type of thickening? If it is diffuse or symmetrical, then we are dealing with benign, or otherwise it is a focal or asymmetrical or diffuse or oblique focal and asymmetrical, then likely malignant. If the mucosa is intact, then it's benign. Otherwise, discontinuous mucosa indicates malignancy, and layered pattern of the GB wall. So internal external layer is preserved in benign cases and it is lost in malignant cases. So ultrasound is, friends, very important tool, and if you have a good ultrasoundologist, he will provide you a lot of information which will help you to decide the nature of this thickening. Color Doppler and shear wave elastography parameters, you can ask for it, but the things given in this red rectangle are sufficient to differentiate between two things. Again, this is a very good paper again from PGI Chandigarh, that they have given the concept of GB RADS, and it's like similarly as we deal with the BI-RADS or LI-RADS. So this is based upon the ultrasound. So based upon this GB RADS, they have given 5 categories. So 1 and 2 are normal and benign. If there is adequate gallbladder distension, wall thickness is less than 3 mm, the chance of malignancy is 0. It is symmetrical circumferential thickening with or without intramural changes, or focal thickening with intramural changes, or layered appearance preserved, interface with the lever. So if these things are there, then most likely we are dealing with benign thickening, and the chance of malignancy in these cases are less than 2%. Equivocal, the dilemma will come when there is circumferential thickening without layered appearance, or focal thickening without intramural features. Intramural features means there are some findings in the wall of the gallbladder. We will elaborate more in the CT part of the evaluation, that there are cyst or echogenic foci. If they are present, then it will be most likely we are dealing with benign, which favors xanthogallbladder cholecystitis, or if there is a layered appearance. So all these features like circumferential thickening without layered appearance, or there is layered appearance without echogenic foci, or focal thickening without intramural changes, these all are basically red flag sign, and the chance of malignancy, this is the basically dilemma. So there are 2 to 50%. Likely new if there is circumferential or focal thickening without layered appearance or with loss of interface with lever, and malignancy if there is a definite extramural invasions. So 4 and 5 is clearly malignant. We have to proceed with basically other evaluation like tumor marker, CT scan, and this patient will be restricted to the external cholecystectomy. Equivocal is the basically area where we have to concentrate further, and part 1, part 2, that is category 1 and category 2 are benign. You can simply proceed with the lab chole. So contrast enhanced ultrasound, this is a newer modality. It has an established role in the lesion of liver and kidney, but the role as per se in the gallbladder lesion is not so well defined. And the normal GB on contrast enhanced ultrasound, there is a uniform enhancing wall without discontinuity. So the mucosa is regular, wall is regular, there is no discontinuity, there is a proper layered pattern, and study shows that there is a better diagnostic performance of contrast enhanced ultrasound as compared to MRI for differentiating malignant and benign lesions. But to sum it up, we don't have any concrete evidence, and its role is yet evolving and yet to be defined. So any case of thick-walled gallbladder will require evaluation with the CCT, that will be biphasic CT scan of the abdomen, and it is the gold standard investigation while evaluating a thick-walled gallbladder. So these are some of the pics from a patient with the gallbladder cancer. The figure A is heterogeneous enhancing thick one layer pattern, arrowheads. And figure V is intense enhancement of inner layer, white arrow, and weakly enhanced or unenhanced outer layer on portal phase. So these are some of the findings, and as a trainee you should always look at these films, discuss these CTs with your radiologist, so that you have a better understanding. And with time, believe you me friends, if you keep on seeing these CTs, then you can analyze or diagnose better as compared to any other radiologist who's seeing all the patient. But when you focus on one entity, then you can diagnose better. So xantho will remain basically the differential diagnosis which will trouble you all the time, and it is very difficult at time to differentiate, but there are some telltale signs which will help you to decide that it is favoring xantho or malignancy. So in this case, there is a diffuse GB ball thickening and intramural nodule, as highlighted by arrow, favoring xanthogallbladder cholestatis. Intramural hypoadenitic nodules have been reported, which represent xanthogallbladder cholestatis. So as I was saying, if there are these foci or cystic changes in the wall of thick-walled gallbladder, so these favor xantho. Otherwise, irregular, unenhancing part and focal thickening, these will favor malignancy. So if they symmetrically whole gallbladder thickened, there is a grossly thickened gallbladder with some changes in the GB wall, that is intramural nodules or foci or cysts. So these favor xanthogallbladder cholestatis. So friends, I will end this video here, and the next our discussion, next part we will uploading soon. So we will discuss about IgG4, Xantho, then the Lucknow approach, then the surgical approaches, and the key takeaways. And we will also try to demonstrate one small video about the how much is the extent of dissection in case of extended cholecystectomy. And as I said, for exclusive and early access to the SD content, download the app or join the channel and membership. The link for everything is given in description and pinned comments. So if you have any questions or any doubts regarding this talk, you can connect to us in the comment section on YouTube or through the chat option available on our app. So I'll see you soon in the next episode. Stay tuned for more educational content, and as always, keep striving for excellence in your surgical journey. Thank you very much. Happy learning.